All right, so this is the December 2023 MEC Minute. It's really kind of the end of the year, and this is the end of the year mishmash. So what I've got to talk about is little odds and ends, all of which relate directly to the protocol and the protocol for next year, which is why it's a mishmash. So what we're going to talk about is a little bit about some changes that the MFATS board made earlier this month in terms of competencies for paramedics and EMTs. For EMTs, it's a pretty substantial change, and I'll get into some details. I'm going to provide an update on some pending protocol updates. So there's some things that are in the works that are going to affect the protocol, such as EMTs and their change of scope, but also in terms of other items such as adjustments in our behavioral protocol because of shortages we're facing with ketamine and some discussions among the regional EMS medical directors. So we have a lot of irons in the fire, and I'm going to push back the start date of the 2024 protocol because of these irons that are in the fire. So we're going to give an update on the protocol, the effective date of the protocol, as well as what that delay does in terms of our protocol assessment and the provider annual recredentialing and the timeline for that. So I'll get into some details. Despite all that, we do have a couple changes to the protocol for 2024. I'm going to discuss that. Not a lot of big changes, none of which should be big surprises, many of which I've talked about in previous MEC minutes this year. And then I'm going to spend a considerable amount of time talking about the ketamine shortage that we're facing and alternate medications that are out there. And we're going to specifically talk about etomidate for DSI. Etomidate is already on our drug license as an alternate to ketamine for intubation. And I'm going to talk about discussions we've had among the area medical directors regarding use of droperidol for behavioral emergencies. And that's, how can it be used in those circumstances where we have a ketamine shortage and only limited amount of ketamine in stock. And then we've had some questions over the past 6 months about our Heads Up CPR program. And I'm going to discuss a little bit of our 6 months experience with that. So getting on in terms of the MFAT, so there's been a lot of conversation over the past couple of years about paramedics and ultrasound-guided peripheral IVs. A lot of start and stops. Well, the MFATS board at their December meeting added ultrasound-guided IVs to paramedic competencies, and they are making administrative rule changes that are supposed to be posted the first of the year. And essentially, those rule changes will allow peripheral IVs via ultrasound guidance. So we'll look at that in the future, but we're not quite ready to bring that into prime time, particularly since the administrative rules haven't been posted yet. The other change, which I think is big for EMTs, is the board has recognized that EpiPens are outrageously priced at about $300, if not higher, and that many of the agencies that rely on EMTs for primary staffing can't afford EpiPens. But epinephrine is available. It's 1 to 1,000. It comes in a vial. And the board has allowed now EMTs sometime after the first of the year to draw epinephrine up from a vial into a syringe for intramuscular injection for patients who are suffering an acute allergic reaction. So we are looking at that in terms of how we can make adjustments in our protocol. Those adjustments won't be made until the administrative rule has been formally posted by the board, so we know what they say. I anticipate that there's going to be changes, and as part of that for IM epinephrine, we will have to identify a protocol and a teaching program for the EMTs. More and more of our departments are employing or hiring EMTs because paramedics are not available. Epinephrine for acute allergic reactions can be life-saving, and EMTs should be able to administer it. So we will develop a protocol for that, and we will identify a training program under which the EMTs will have to go through in order to be credentialed to administer intramuscular ketamine after drawing it up from a vial. The other thing we have to look at from our protocol update is ketamine and the shortage. We have a tremendous shortage of ketamine right now. Our supply is spotty. So the medical directors, Drs. Cortez, Dr. Lowe, Dr. Larimore, Dr. Orth, and I, as well as a few others, have started talking about alternatives to ketamine for behavioral emergencies. We have in our current protocol Haldol as an alternative for ketamine for behavioral emergencies, and etomidate is available as an alternate for intubation. So we can make that substitution. But the medical directors think that droperidol is a better drug for behavioral emergencies than Haldol. So later in this conversation, I will talk about why we're removing Haldol to the alternative drug list and adding, probably going to add droperidol. And I'm also going to review etomidate from the perspective of what you need to know since you may have not had any experience using it. What all this does is it's kind of changing our timeline. So typically, protocol comes out, it's effective January 1st. Well, I'm pushing it back to January 22nd. That should give us some time to take into consideration what the MFATS board has said regarding EMTs and adrenaline, and will also allow the Central Ohio Medical Directors to finalize their plans for use of droperidol. If we're going to push back the effective date on the EMS protocol, then the protocol assessment's really not going to come out till around the 22nd of January as well. And the deadline for completion of the assessment by all of our providers is going to be pushed back to the end of February or the 29th. We have for several years had a provider credentialing and recredentialing program. There's a spreadsheet that's completed by the coordinators that verifies that our providers have met the requirements. I'm pushing that back a month from the end of February to the end of March. So everything's kind of cascading because we're delaying protocol release. So what are we doing in terms of actual protocol changes that I can talk about today? Well, we are taking CPAP, and wherever CPAP is in the protocol, we're substituting BiPAP. So BiPAP will be in the protocol for our adults and children. This is a paramedic level procedure, and we discussed that in the November MEC Minute. Spent a lot of time talking about CPAP and BiPAP. The device that we're using can be used in CPAP or BiPAP mode. EMTs and advanced EMTs continue to use CPAP, but they would just have to use the CPAP mode of the device. We've made some adjustments in the post-resuscitation protocol that I'll get into momentarily, and there's been some adjustments in the traumatic brain injury protocol or head injury protocol. And if you recall, we talked a lot about TBI in the August MEC Minute. So from post-resuscitation, this is the new version of the protocol. What have we done for changes? Well, we've made one change, which is after ROSC, we need to optimize the patient's hemodynamic status, and we need to basically stay on scene for 5 to 10 minutes to make sure the patient doesn't re-arrest. Once the patient has ROSC, they're at risk to re-arrest. From my perspective, if you have ROSC, it takes time to package the patient anyway. So take your time, make sure the patient's stable, and be prepared for the patient to arrest again. Another thing we've done is if you have a patient and you have ROSC, mix up a 1 to 100,000 solution. You take a milligram of epinephrine, you take a vial of 1 to 1,000 epinephrine, and you mix it in 100 cc's of saline. That will give you a 1 to 100,000 solution. So we're not going to wait to see if the patient re-arrests or is hypotensive. If you have ROSC, mix it up, have it on standby. And then you can either start an epinephrine infusion at 2 to 10 mics per minute, or you can do push dose, which is basically drawing up 1 or 2 cc's of the 1 to 100,000 solution, and you give it IV push every 3 to 5 minutes as needed. This is the same procedure you follow if you have a patient who requires DSI and is hypotensive. You mix up the 1 to 100,000 solution and you give push dose epinephrine to get the blood pressure that you need. So it's something that we've already got in the protocol elsewhere. We're now adding it to post-resuscitation. And here's some additional information on push dose. So it's in the protocol. We're adding another indication. Patients post-arrest, they're hypotensive. We can use push dose epinephrine to obtain an adequate blood pressure. The other change we're making has to do with head trauma, so TBIs. And this is the new version, again, calling out the specifics. Any patient with a head injury should get oxygen. So if you go back to the August MEC Minute, we know that hypoxia is one of those things that results in bad outcome. If a patient has an episode of hypoxia at any point of their EMS care, their risk of complications at head injury doubles just because they had an episode of hypoxia. So we're going to hyperoxygenate patients. We're not going to worry about causing free radical formation or anything like that. We want these patients to be well oxygenated. So if the patient has a head injury, they get oxygen. We're also going to be less tolerant of hypotension. So if you look at our permissive hypotension protocol for trauma, we shoot for a goal of 90 millimeters of mercury as a systolic blood pressure. Well, if the patient has a head injury, we know hypotension also kills and causes bad outcomes. So our goal is to get the patient's systolic pressure up to 100 milligrams, 100 millimeters of mercury with an IV fluid bolus. So we're adding fluid therapy as a bolus. We have a different acceptable threshold for systolic blood pressure in a head injury patient versus someone who has generalized trauma. We're also going to avoid hyperventilation. So if the patient requires a supraglottic or an endotracheal tube, we're going to use capnography to monitor their CO2 levels. And our goal is for a end tidal CO2 of 35 to 45. We do not want to hyperventilate these patients. So if the patient has a head injury and you need to provide an artificial airway, our goal end tidal CO2 is 35 to 45 millimeters of mercury. And finally, TXA. So in the past, we've had TXA for mild to moderate head injuries. We've gone a step further. We've defined what level of injury is suitable for TXA. So in a case of isolated head injury, a GCS of 9 to 12, patient should be given TXA. If it's less than 9, TXA has no proven benefit. If it's over 12, they really don't need it. So the highest risk patients, or the patients who are most likely to benefit from TXA, are those with a GCS of 9 to 12. So GCS of 9 to 12, no other injuries, they get TXA. So they don't have to be bleeding out in order to get TXA. They need an isolated head injury with a GCS of 9 to 12. Moving on to ketamine. So ketamine, like I mentioned, supply is spotty. If you look at our protocol, we have a list of drug substitutions. It's in the protocol. And what it does is it pre-authorizes any particular member agency to use a substitute medication if the drug of choice is in short supply. And you don't need permission. There does not need to be a separate protocol. So for ketamine, we have etomidate available as an alternate medication for DSI, and we have Haldol as an alternate for behavioral. We are going to remove Haldol. We're going to add Droperidol. In the past, if you've been with us long enough, you'll remember the days when we used etomidate to sedate patients. Well, we're going to now use it if we have a patient who needs intubation and ketamine is not available. You can make the drug substitution. Today is the time you're receiving training on etomidate. You can use it, and you don't need to have any special waiver from me regarding the protocol. So etomidate is 0.3 milligrams per kilogram, up to a max of 20 milligrams. We really shouldn't use it in children under age 8, and our total dose is, again, 20 milligrams. We have no substitute for ketamine in terms of pain control, so it's fentanyl, fentanyl, fentanyl. If you don't have enough ketamine, just go with the fentanyl. So a little bit more information on etomidate. It previously was in our protocol for intubation. It's our backup medicine in our protocol for ketamine and DSI. It can be used in adults and for children over age 8. It is a non-barbiturate hypnotic agent. Basically, it puts the patient to sleep. It gives them amnesia for what you're doing, but it is not an analgesic. It doesn't work for pain. So if you have a patient who receives etomidate and they have a painful injury or other painful condition, don't forget the fentanyl. Etomidate will not help control pain. It only helps with sedation. So for DSI, there is no change. If the ketamine is unavailable, use etomidate. It's just a drug substitution. There's no change to process. We can use it for adults and kids over age 8. It's 0.3 milligrams per kilogram, either IV or IV, over 30 to 60 seconds to a maximum dose of 20. So if you have an average patient, give them 20 milligrams. Don't worry too much about the math. From the side effects perspective, they may get a little bit of stiffness. The most significant thing for us, I think, really has to do with trismus or clenching of the jaw. from my experience, most patients who get etomidate need a paralytic in order to get the jaw relaxed enough that you can visualize the cords and get a tube appropriately placed. So expect the jaw to be stiff, and then you're going to need a paralytic to get the patient intubated. The other side effect, which really for us is not too big of an issue, is it can cause a suppression of the adrenal gland for 24 hours. The adrenal gland is the source of cortisol, which is a stress hormone. It's a cortisone, or like dexamethasone, a steroid. There's been some studies to suggest that it will suppress the adrenal gland, which may be a problem with trauma patients. From my perspective, if you have a patient who's had trauma and needs an airway, the greater risk to the patient is loss of airway rather than adrenal suppression. Give them the drug, get them intubated. An advantage to this is it sometimes can cause hypoventilation and apnea, but it has no effect on blood pressure. It can depress respirations, but not too much. And it does have a potential effect of decreasing intracranial pressure. So etomidate has been used by us for almost a decade very safely. And then we substituted ketamine because ketamine covered so many bases in terms of our treatment needs. Moving on to droperidol. So droperidol, also known as anapsine, anapsine is the trade name. It's an antipsychotic. It's in the same family as Haldol. And the advantage over Haldol is it tends to work faster. Primary or indications for its use is we used to use it a lot for nausea and vomiting. I still use it for nausea and vomiting in patients who have refractory vomiting. It does not improve with the typical drugs like Zofran. It seems to be very good for patients who have cannabinoid hyperemesis syndrome, those patients who overindulge with marijuana and now have nausea, vomiting, and abdominal pain. It works well for aborting headaches, and it also works well for behavioral emergencies. It has two side effects that you need to be aware of. One is that it can cause extrapyramidal effects, meaning Parkinson's-like effects or dystonic reactions. Patients can get stiff, their tongue can deviate one side or the other. Sometimes they even look like the patient's having a stroke. They're not. It's a dystonic reaction or an extrapyramidal reaction to the medication. The other thing is it's been associated with torsades, which I'll talk about in a minute. The reason we're bringing it up now is two reasons. One is ketamine is in short supply and we need to identify alternatives. The other is the American College of Emergency Physicians in October issued a clinical policy on the management of adults who have either out-of-hospital behavioral emergencies or behavioral emergencies in the emergency department. In that document, and I'd be glad to send you a copy if you want, just let me know, but in that document, it lists droperidol plus midazolam as more effective than ketamine in many circumstances. Now, ketamine was the drug of choice for patients who were violent and needed immediate control, but for the average run-of-the-mill behavioral emergency, the policy actually prefers droperidol plus midazolam. So that's why we're talking this through. The Central Ohio medical directors are talking about revising our shared protocol on behavioral emergencies, and that's where droperidol is going to come into play. So droperidol, I mentioned torsades. In 2001, the FDA issued a black box warning on droperidol regarding the risk of QT widening and torsades. As part of that warning, they made the statement that if you're going to use droperidol, you need to get a 12-lead ECG before you dose the patient and monitor the patient for 2 hours after, to which many of the ED providers said, yeah, right. So if we're using it for behavioral emergencies, we don't see a patient sitting still for a 12-lead. But we also have to consider what's happened since this black box warning came out. If you look at the original warning, it was based on 65 case reports and basically 65 patients who had adverse effects resulting in torsades out of the tens of thousands, if not hundreds of thousands of patients who received this drug. Most of these case reports were for patients who received extremely high doses of IV droperidol, like 25 to 250 milligrams IV. We typically use anywhere from 2.5 to 10 milligrams IV. And many studies have shown since then that droperidol is very safe for IV and use or for IV management of nausea and vomiting, particularly less than 2.5 milligrams. So since then, the FDA has said, well, if you're using less than 2.5 milligrams IV, you don't need to do any of this. But there have also been many studies out there that show higher doses, even doses over 10 milligrams IV, have been used for behavioral emergencies without adverse effects. So droperidol for many physicians, particularly those who've had experience prior to the black box warning, is that droperidol is a good drug, and it's got a bad rap based on a very few number of case reports. So what are we talking about? So the medical directors have talked about adding droperidol as an alternative medication for behavioral emergencies. And this is kind of what Gordon Griggs has put together for us. This is similar format to what our behavioral emergency looks like for ketamine. But essentially, we're talking about using droperidol for SAT scores of +2 and +3. And it's based on weight. So if you're 100 kilos or more and a +2, you'll get 5 milligrams of droperidol plus 5 of midazolam. 50 to 99, it's 2.5 and 2.5, and less than 50, it's weight-based. If you're talking about a SAT score of +3, it's going to be basically we've doubled the doses. And we also recognize that if the patient doesn't have a good response in 10 minutes, you can give a half of the original dose of midazolam. So they get 1 dose of droperidol, but they can get a second dose of midazolam. So this is what we're talking about. Gordon thinks he can actually take this algorithm and blend it with the one of ketamine, so you have a choice between ketamine or droperidol. We're going to figure that out over the next couple weeks. So if you think about this for kids, it can be used. There are treatment protocols out there for children to receive it. I've been talking with our pediatric friends, and we're not sure how we're going to fold it in yet, but I suspect we're going to say you can use droperidol, but the child has to be 25 kilos or more. The other thing about this protocol is we're going to revisit this with the protocol assessment. I've got the protocol assessment written. There are some questions in there about droperidol. And when I record the video, that is our assessment review of the questions, I'm going to revisit droperidol, and we'll talk more about this algorithm and how we're going to get it set up. So for droperidol and safe use, if we use droperidol, we have to realize that the patients are at a potential risk. So as soon as possible, when the patient's calm enough, we're going to get a blood pressure, we're going to get a finger stick blood sugar, we're going to place them on a cardiac monitor, and we're going to watch the QT interval. We're going to put them on continuous pulse ox, and we're going to keep them on capnography. Now, this is no different than what is expected in the protocol for behavioral emergencies that get ketamine. So no change in process other than an emphasis on watching the QT interval. Our first concern is to get the patient safely sedated. The second concern is to get appropriate monitoring in place to keep the patient safe. Just a couple comments about QT interval. What is it? Well, if you're like me, the first thing I do is I go to the 12 lead and let the 12 lead tell me what the QT interval is. But the QT interval is really measured in leads 2 or V5 and 6. It is this period right here, and it's beginning of the Q wave to the end of the downslope of the T wave. So underneath that upper monitor strip, you'll see the red lines that are showing you where the QT interval ends. I'm showing this for the purists who want to make their own calculations, or if the patient's on a simple rhythm strip. But you need to look at the interval. For me, I would turn the cardiac monitor on, do a quick 12 lead, and let it tell me what the QT is. But for men, a normal QT is less than 440 milliseconds. For women, it's less than 460. If you have a QT interval more than 500 milliseconds, you're at increased risk of torsades. If you've medicated the patient and the QT is more than 500, keep your eyes open. Normal QT, just an easy way to look at it is a normal QT is less than half of the RR interval. So you look at that RR interval, 1 hour wave, peak of 1 hour to the next, that's whatever it measures out to, half of that is what your QT interval should be, or less than that. So these are quick reminders. I'm bringing it up because we need to talk about droperidol and the potential side effects. So let's see what happens. So suppose the patient develops an episode of torsades. What are we going to do? We're going to treat it. It's often short-lived. It often is self-terminating. But if you have an IV in, we're going to treat that patient with bag sulfate. We're going to think about cardioversion. And rates that are over 220 often degenerate to VF. Again, we're reviewing this because patients may receive a dose of droperidol. We need to be well aware of its side effects and be aware of the complications. Also be aware that there are other things that can cause torsades, electrolyte imbalance like hypomagnesemia or hypokalemia, tricyclic overdoses, antihistamine overdoses can cause it, as well as other antipsychotics. So we did have Haldol in our protocol as an alternate to ketamine. Well, Haldol is also known to potentially cause torsades, but it hasn't gotten the black box warning. So if you think about this, so we're talking about all this because of ketamine. Well, if we have a ketamine shortage, how would I prioritize its use? So you have limited supply on the truck. Some patients should get ketamine. Some patients, we're going to avoid giving them ketamine. We're going to use some alternate medications because our supply of ketamine is precious and we are very short. So my first priority for ketamine, it's on the truck. Who would be my first priority to receive it? Is that patient who is a +3 SAT, behavioral emergency, and they need immediate sedation. And to me, they are an immediate threat to themselves or others. So, there's a +3 SAT that's agitated, pulse, they're pacing, they're loud, but they're not violent. They're not an immediate threat. I would give them droperidol. Patients who are immediate threat to themselves, care providers, or others, I would use ketamine. There's nothing that works faster. Droperidol works fast, but ketamine is faster. My second priority for ketamine would be pain control. So if we have a patient with a painful condition, they've got a broken femur, they've got a major thermal burn, and fentanyl's not cutting it, I'd break out the ketamine. My third priority for ketamine would be the patients who are +2 or +3, and we have 5 to 10 minutes. I would probably de-emphasize ketamine and I go to droperidol midazolam. These patients need sedation. But we can take a little bit of time, get them dosed up with the meds, and it'll let droperidol work before you transport. If ketamine's really short, I think the last thing I would use it for would be DSI. I'd use etomidate. Put it on the truck. We've used it in years in the past. It is a good alternative to ketamine. The main reason we went to ketamine over etomidate is we wanted to simplify our drug license. Well, it's already on our drug license. It's available. We can use it safely. Be aware of its side effects, but use it in the same fashion as you would ketamine to intubate the patient. Finally, just a couple comments about our heads-up protocol. So three different things I've heard. One is, as part of the heads-up program, we've adjusted our termination and resuscitation protocol. We've got 5 rounds of epinephrine. The patient's still in arrest. We're 20 minutes in. What do we do for the next 10 minutes? Well, from my perspective, it's still reasonable to stick with 30 minutes. Take that time to reassess. Take that time to talk with the family. We are resuscitating your loved one. They are not responding. It's time for us to discuss termination. So for now, we are not going to change termination from 30 minutes back to 20. I've talked with other medical directors, and they are at 30 minutes as well, and they are sticking with it for the same reasons. Keep it going. Talk with the family. We've also heard comments about the Lucas and the heads-up wedge and moving the patient. So it does shift a lot. It can be bulky to move the patient with the wedge and the Lucas. I understand that. Those are work process issues. Even if the device is appropriately placed, the neck strap is on and tight, there is that effort. But, if we're working the patient for 30 minutes, is it really time to move the patient? Particularly if we're talking about patients who are in a PEA arrest or a systolic arrest. So I'm aware of these concerns. Should we revisit the Eligard, things like that? I'm not sure yet. I think we need to get a little bit more time under our belt. Continue to send your comments in using the QR code that we sent out there. I read those comments and I share your concerns. I understand what you're saying, but it's not quite time to make any decisions or recommendations for change. The last thing is, has the heads up made a difference in our cardiac arrest outcomes? I looked at the CARES numbers just this week. Really, the numbers, we don't have enough information yet to say if they're working or not. So we've had a reasonable number of arrests, but the final outcomes aren't listed. It's not time to look at the CARES data yet and make any recommendations or decisions. So bottom line for heads up is it's a work in progress. I understand there are concerns. We are continuing to monitor it. I don't have any qualms about going back to the old way, but we have to give this an adequate trial before we make decisions. So more to come on that. Again, just a comment, too soon to tell. Let's bear with it. Let's see what happens. So in summary, relatively few changes to the 2024 protocol, mostly to head injury and post-arrest patients. We will be adding EMT administration of epinephrine. In terms of the protocol, that's relatively easy to add, but we need to work on the training that goes with it, and that will be required by the board. If ketamine's in short supply, we have alternatives available. If the first priorities are for use of violent behavioral health patients and for pain control, otherwise we have etomidate and droperidol available. Update your knowledge on etomidate. There's a medication information sheet in the protocol. You can, based on your agency's supply of ketamine, make a decision to go to etomidate without any formal changes or sign-offs by me, although I do want to know if you have to make the substitution. Droperidol's on the horizon. I think it will be added to the protocol. I think it has a place. But you need to understand its indications and cautions. And then for now, no change in heads up and TOR or termination resuscitation, but keep the comments coming. We do look at it. We will discuss it at the bi-monthly coordinators meetings. So that's it for the December MEC Minute. It was a mishmash, but it is all related to the protocol, and hopefully it all makes sense to you. If not, please send me an email. Otherwise, thank you. Have a safe and happy holiday.